نعتز بصداقة حضرتك
لا يا
وحاجة
فندم،
بصراحة
أنا
شرف
ده
لنا.
شرف ليا، ده شرف
عارف
ليا
حضرتك دي من أيام، من قد إيه، بقى لنا حوالي 25 سنة دلوقتي، من أيام
سبحان الله. يعني ما بين رسالة الدكتوراه كانت فين ده؟ في 2004 مثلا، حاجة كده.
دخلنا
اه
على
2004، 20 سنة.
20 سنة بالظبط.
20 سنة
ربنا يديك الصحة يا
أنا
فندم.
مناقش 2004 أعتقد.
وهي كل بنها بتذكر حضرتك بكل خير، الدكتور شيرين والدكتور جمال والدكتور أسامة والدكتور عادل، كلهم بيذكروا حضرتك بكل خير يعني.
ربنا يخليك. دكتور شيرين ده أستاذي
ربنا
وأنا
يكرمك حبيبي.
أعتز بيه، ودكتور جمال طبعا يعني العالمية كلها، ودكتور أسامة ده والدنا كلنا.
ربنا يديك الصحة يا فندم.
كلهم أصحاب فضل ودايما الواحد يعني يفتكرهم بكل خير.
ربنا
وانت
يديك الصحة.
خير ممثل للجيل العظيم ده.
ربنا يكرمك دكتور ايمن بيه، ربنا يكرم حضرتك. والله انا اللي بيبسطني قوي الحمد لله ان احنا دلوقتي يعني احنا بس we have 5 minutes to start، فانا نقدر نتكلم مع حضرتك فرصه شويه. يعني
تمام.
انا بشوف الزملاء اللي بيجوين كاتنديز ما شاء الله، من الجزائر ومن تونس ومن اليمن ومن سوريا ومن العراق، ويعني يعني الدول العربيه ما شاء الله حتى اكتر من المصريين. يعني انا سعيد جدا بالزملاء من كل الدول العربيه بصراحه.
صدقني الناس اللي اتحرمت من تواجدها في مكان للتعليم، يعني انا وانا خارج من القصر العيني مثلا، اتخرجت من القصر العيني وخدت الماجستير من القصر العيني، وبعدين رحت خدت الدكتوراه، يعني رساله الدكتوراه في بنها. وبعدين سعيت في ان انا اتعلم في الان اتش اس، يعني لانها برضه مجال للتعليم كبير.
طبعا طبعا.
فالناس اللي ما عندهاش مصدر للتعلم، دي يعني محنة. يعني حضرتك النهاردة أنا ببقى متعاطف جدا مع واحد مثلا يحط على جروب من الجروبات: يا جماعة دي فور ارم فراكشر، أعمل فيها إيه؟ أنا عارف أعمل فيها إيه وأنت عارف تعمل فيها إيه. بس الديسيجن ميكنج ده والتعليم مهم جدا.
وهي دي
مهم جدا.
وظيفتنا يا فندم، دي وظيفتنا حضرتك.
ومش بس الموضوع
احنا
بيقف
موجودين
في إن
عشان كده يا
أعمل
دكتور
إيه.
ايمن بيه.
اه
يعني في اخ فاضل من ليبيا اهو قاعد بيشكر حضرتك وبيسلم على الزملاء كلهم من ليبيا. فيعني كلهم بنشرف بيهم والله والله،
صدقني
وبيسعدونا،
صدقني هم يعني على
وبيسعدونا
راسنا
اشد
من فوق.
السعاده بصراحه.
زملاء أفاضل، وإحنا نعتز بيهم طبعا. ويا رب اللي إحنا بندرسه ده يكون مفيد ليهم في البراكتس بتاعهم.
والله ديفنتلي يا فندم، يعني الحمد لله. والواحد وجد فيهم اخوه افاضل، يعني عندهم ايجر للعلم وللتعلم، وعندهم شغف بان هم يبقوا ابديتد كلهم صراحه يعني.
طبعا.
ربنا يجعلنا في خدمتهم يا رب.
يا رب، أمين. أمين.
اخبار
أنا
المستشفى الجديده
النهاردة
يا
كنت
دكتور ايمن بيه؟
بستلم العمل الجديد
وانا
والبوزيشن
لسه بسال
الجديد.
اهو، اخبار المستشفى الجديده ايه؟
لسه كنت بستلم امبارح. كنت هناك، وبعدين لقيت وانا قاعد في العياده كده معايا زملاء اللي انا اعرفهم من قبل كده، لقيت حد داخل: دكتور ايمن، انا اعرف حضرتك، تعرفني منين؟ عشان انا بتابع دكتور محمد الاشد.
ربنا يكرمك يا فندم، الحمد لله.
فما شاء الله عليك، ليك
الحمد لله الحمد
متابعين
لله.
ومريدين.
ده فضل من ربنا سبحانه وتعالى ان هو يعني
طبعا.
ربنا لما
طبعا.
يحبنا يا فندم يجعلنا في خدمه الناس، بس هي دي
طبعا.
دي دي
طبعا.
فضل من ربنا علينا يعني.
اكيد.
ان احنا
وبعدين
ربنا يا
احنا
دكتور
مش
ايمن
بس.
بيه يسرنا لان احنا حد يتعلم يعني بسببنا او على ايدينا، ده فضل كبير من ربنا علينا يعني.
طبعا، الحمد لله. الحمد لله.
ربنا يجعلك دايما صاحب فضل يا دكتور ايمن بيه على الناس كلها يعني.
احنا كلنا بنساهم بحاجة بسيطة جنب اللي بتعمله يا دكتور محمد.
الله يديك الصحه يا فندم، ربنا يديك الصحه يا فندم. وي ار ريدي يا فندم. نبدا اقدم حضرتك على ما الاخوه الزملاء
دقيقة واحدة
يبداوا
بس،
يسمعوا.
معلش.
براحه حضرتك، اتفضل.
معلش. ايوه، اتفضل. اتفضل
بسم الله
سعادتك.
الرحمن الرحيم. طبعا انا يسعدني ويشرفني ان يكون موجود معايا النهارده يعني اخويا وزميلي وصديقي العزيز دكتور ايمن سوريال، كونسلتنت تروما اند اورثوبيدكس ان اتش اس يو كي. دكتور ايمن من بغض النظر عن ان هو جراح اكثر من رائع، هو محاضر اكثر من رائع. محاضرات الدكتور ايمن يعني بنعتبرها ان هي ريفرنس نرجع عليه في اي وقت وفي اي زمان ومكان. دكتور أيمن، أنا عارف إن إحنا ضغطنا على حضرتك في المحاضرة دي والوقت كان ضيق، وإن حضرتك لسه راجع من مصر، بس إحنا يعني معلش إحنا دايما يعني بنرجع لحضرتك في المواقف الصعبة. فمرحبا بيك يا دكتور أيمن بيه معانا النهارده.
مرحبا بيك يا دكتور محمد. أنا متشكر جدا للدعوة الكريمة والفرصة الجميلة دي إن أنا أتكلم في حضور حضرتك. وكفاية إن أنت يعني أنا بقول دايما مرة واثنين وثلاثة إن حضرتك عملت نقلة نوعية في التعليم الطبي عن بعد، وجمعت الشرق والغرب، وجمهور حضرتك بيمتد من المحيط للخليج، وأنا بقول لك كمان من أوروبا شمالا لجنوب أفريقيا جنوبا. ليك ناس بيتابعوك، وأنا يسعدني دايما المشاركة معاك بغض النظر عن ضيق الوقت. لو تحبوا نبتدي أنا تحت أمركم.
اتفضل سعادتك يا فندم، احنا جاهزين يا فندم.
طيب احنا النهارده هنتكلم ومش باستفاضة شديدة عن موضوع هيقابله أي حد بيشتغل تغيير مفاصل في حالة وجود ريفيجن توتال هيب ارثروبلاستي، وهي وجود الacetabular defects bone deficiencies during total hip replacement revision. أنا اسمي أيمن سوريال، أنا consultant trauma and orthopedic surgeon with a specialist interest in arthroplasty and hip fractures, Northwest Anglia NHS Foundation Trust. كintroduction بنقول إن acetabular deficiency is a commonly encountered during revision hip surgery. and مش بس البوني deficiency بيبقى ليها تبعيات. التبعيات بتاعتها ان بيبقى في proximal migration of the hip center of rotation. There's a number of techniques that we can use to address this problem. حجم المشكلة دي بنقول ان about 10 to 15% of hip arthroplasty patients will undergo revisions at 20 years. يبقى حجم العمليات اللي هتتعمل كريفيجن توتال هيب ريبليسمنت طرديا مع عدد البرايمري ارثروبلاستيز. اسباب الريفيجن بتكون aseptic loosening، ده من اكبر اسباب الريفيجن، instability وديسلوكيشن، prosthetic joint infection وما يتبعه من osteolysis وخلافه. Each failure mode can lead to acetabular bone loss بشكل او باخر. The successful management of complex acetabular defects and pelvic discontinuity requires careful preoperative planning. دي ما هياش العملية اللي حد يقدر يقول إن أنا هخش النهارده أعمل عملية من غير ما يكون محضر كويس جدا. Specific operative techniques and the comprehensive understanding of implant design, bone ingrowth potential and bearing materials. كتقدير لحجم المشكلة في اليو كي في around 8,500 revisioned arthroplasty procedures are done every year. ما نقدرش نقول تحديدا قد ايه منهم بيتعمل فيه acetabular reconstruction. طب ايه سبب البون لوس؟ بون لوس can occur as a result of mechanical loosening. مجرد ان في loose component سواء في ظهرها في سيمنت او porous surface ما حصلش ingrowth، هيبقى في حركه ومايكرو موفمنت او ماكرو موفمنت will lead to migration and progressive bone loss. في اسباب تانية ممكن يحصل osteolysis كادفيرس رياكشن عن طريق البارتيكوليت ديبريس اللي بينسايت local reaction ويبتدي يحصل release of chemical mediators that encourage the osteoclast to resorb bone. Corrosion at the metal interface سواء عند الموريس تيبر أو لو في metal برضه بيجنريت particulate debris اللي بيسبب نفس المشكلة. Successful management of acetabular deficiency depends on a number of factors. أول حاجة لازم يكون في thorough pre-operative assessment and exclusion of infection. هنتكلم عن ده تحديدا. الايميجينج والبلاننج مهم جدا. احنا عندنا كذا موداليتي من اول بلين راديوجرافي للسي تي للام ار، ولازم ان احنا نشوف ايه فايده كل حاجه من الحاجات دي. الامبلانت سelection، ايه الامبلانتس الموجوده وهنستعملها ازاي، ومانجمنت اوف اوستيوليسيس وريكونستراكشن، بون جرافت هنستعمل اني بون جرافت، وبعد كده في البوست اوبراتيف مانجمنت اند فولو اب. بنرجع دايما للبرنسبلز عشان ما تتوهش مننا احنا داخلين نعمل ايه. What are we going to establish؟ احنا داخلين to improve patients' symptoms and complaints. These patient symptoms could be pain, and in that case we have to assess how much pain, and we have to assess the Oxford Hip score. العيان لو ما عندوش much pain, then we don't have much to improve. If the patient is complaining from instability, then we have to assess why does he have instability. We need to assess الابدكتور function. عايزين نعرف ايه سبب الديسلوكيشن، والا يبقى احنا برضه داخلين مش هنقدر ان احنا to manage السبب. وبعدين لازم نعرف ان احنا في two types of stability احنا داخلين to achieve. وداخلين to achieve the implant stability across the bone implant interface، وعايزين stable configuration in terms of articulation، مش عايزين dislocatable hip. And we need to restore the biomechanics, the hip center. We need to bring it as close as possible to the normal. We need to reproduce the offset and height. And we need to restore the bone stock. In terms of planning for revision total hip arthroplasty, we have to evaluate the presenting complaint. Again, pain, how much pain? Does the patient have pain at night? When did the pain start? Did the patient have the pain from the day of his index procedure? Is there a prosthetic joint infection? ده سؤال قد يكون الإجابة عنه صعب. احنا كلنا عارفين ان احنا to evaluate a patient with query infection, we get routine monitoring bloods, we get full blood count, CRP, ESR. كل الحاجات دي بتدينا فكرة. لكن don't forget ان في low grade infections. في infections ممكن يبقى ال CRP معاها طبيعي. يبقى انت محتاج على الاقل تعمل aspiration of the joint to exclude infection. في ناس بيعملوا open biopsy قبل ما يكمت، خصوصا لو عندك شك. ولو عندك شك ان في infection ممكن تتعامل مع المريض على انه عنده infection. دايما بنقول if a thought crosses your mind، لو الفكرة موجودة ما تحاولش ان انت يعني تثبت عكسها، ممكن ان انت تمشي معاها. خصوصا لو انت عندك عيان عمل هيب ريبليسمنت من سنة ونص وابتدى يحصل عنده osteolysis ولوزنينج، العيان ده infected until proved otherwise. مش كفاية ان احنا نقول ان عنده normal bloods. تاني حاجة لازم نفكر فيها احنا واحنا داخلين الهيب ريبليسمنت، this is not a primary hip. انت داخل تشيل الهيب ريبليسمنت، هتشيلها ازاي؟ What tools do you have؟ لو انت عندك ingross acetabular component, removal is not that easy. You need to consider whether you have something like explant, which is the image on your right hand there. This is a successful means of removing a well-fixed implant. وصحيح احنا دلوقتي بنتكلم على potentially loose components, but you never know. Sometimes you would have osteolysis behind the cup، زي حالة هوريها لكم دلوقتي، وانت مش محتاج عايز ان انت تحافظ على الرم. في الحالة دي an instrument like this could prove very important. The soft tissue abductor function. العيان ده هل عنده abductor insufficiency؟ هل بيقدر يعمل Trendelenburg stance؟ الاكسرسايز tolerance قد ايه؟ Consider the stability ladder for the articulation. لو عندك عيان suspected abductor insufficiency, then you need to go to the next step. Do you need a constrained hip? Do you need a dual mobility or tripolar? وبعدين لازم تفكر في الفيمورال كومبوننت، هتشيلها ازاي؟ هتشيلها ب extended trochanteric osteotomy، وهتثبت الفيمور ازاي؟ وايه الكونسيكونسز بتاعت ان انت تعمل هاي هيب سنتر؟ نرجع pre-operative assessment. You should confirm the etiology of failure. لازم نعرف سبب الفيلير. Excluding infection through bloods, deep samples and aspiration. Patient history, index procedure in detail. اتعمل امتى العملية؟ والsymptoms بعد العملية، وهل كان في complications زي either DVT or prosthetic joint infection, what's the patient's cardiac history, and diabetes control and lung function. كل ده مهم. انت محتاج اي عيان هيعمل ريفيجن انت محتاج ان يبقى فيه anesthetic review. كمان لازم ان احنا نعرف ان في مشكله بالنسبه للبيولوجي. العيانين اللي عندهم chronic kidney disease دول عندهم impaired bone function. لو انت مستني ان هم يحصل لهم healing بامباكشن بون جرافتنج ممكن ان ده ما ينفعش. الهايبوثايروديزم مهم جدا. this needs to be worked up as well. The index procedure زي ما قلت قبل كده in detail. لازم يبقى في ريكورد لكل الابروتشز. العيان ده الابروتش اندكس ابروتش كان ايه؟ العيان ده اتفتح قبل كده انترولاترال ولا anterior ولا posterior ولا lateral approach. ده مهم جدا. what are the components؟ ايه اللي موجود حاليا؟ وايه الشركه المنتجه؟ وهل هنعمل single component revision ولا two component revision؟ ولو انت هتعمل two component revision هل انت تقدر تحافظ على one component؟ هل انت تقدر تعمل cement in cement revision؟ كل ده هيأثر معاك وقت العملية، لان انت لو انت بتعمل revision فكرة ان انت to achieve a revision of both sides to the final extent with extraction extended to contractiotomy انت بمنتهى السهولة ممكن العملية بتاعتك توصل معاك 6-7 ساعات. فده برضه كله مش في مصلحة المريض. As I said, risk factors for postoperative instability زي وجود instability prior to surgery, abductor insufficiency, spinopelvic mobility مهم. الincidence angles that the patient have had spinal fusion قبل كده. دي كلها حاجات مهمة وفي a lot of research as regards whether you can antivert the acetabulum even a little bit more, about 30 degrees in the cases of stiff lumbar spine. طيب الأوسيوس اناتومي من غير ما نخش في ديتيلز كتير او نتكلم على الهيب جوينت والكوتيلويد فوسا والليجامنتس، احنا هنا هنتكلم على البوني اناتومي اوف ذا استابلم. احنا كلنا عارفين ان الاستابلم is formed of a fusion of three bones, الإليم والإسكيم والبيوبس والتو column concept which form an inverted Y. في important considerations زي ما حضراتكم شايفين في الجدول ده. differences between females and males. Generally, the females have more inclination, more abduction of their hips, and more anteversion. The radius in females is less than the males, and this is very important لما احنا هنيجي مثلا نتكلم عن ان احنا هنستعمل a jumbo cup. انت تقدر تحط jumbo cup in a male about 60 that fills the proximal to distal dimension. بس in a female لو انت هتيجي تحط cup of 60 هتلاقي ان this breaches the anterior-posterior diameter. You have to realize ان هو jumbo cup in a female is potentially not a very valid option. Posterior wall defects مهمة جدا. ما فيش حد كتير بيتكلم عليها، لكن انت لو عندك limited superior wall انت هتبقى عندك inclination ان انت تحط الكب بتاعتك vertical عشان to implant it in host bone. ولو عندك posterior wall defect you would struggle to antivert your components. دي كلها حاجات مهمة. في حاجة صغيرة في آخر السلايد دي depth of the socket. Depth is the depth of the medial wall. ده مهم جدا لأن النهاردة أنت عايز to medialize your socket. Not to medialize breaching the ilioischial line, لكن lateralizing the socket in revision surgery is very dangerous. لأن أنت you will lateralize it by building up bone. And then you find that you got a very lateral component which is subject to a lot of shear forces. You're forcing your abductors to act in a very short lever arm, creating higher forces around the hip. And then you end up with the component shearing proximally. So be very careful about building up the medial wall. والدبث هنا لو انت عايز تتأكد منه جوه العملية ممكن بدبث جيج ودريل تعرف بالظبط انت ايه الديستنس بينك وما بين الميديال وول. Ideally you should be around these figures. The radiographic assessment ما فيش غنى ابدا عن البلين radiographs. هيفضل plane radiographs هو من الأساليب الأساسية اللي بتساعدنا إن إحنا to diagnose loosening، وإن إحنا نقدر إن إحنا to follow up. مش هتعمل CT serial CT scans. CT scans are for preoperative planning. Looking at a plain X-ray, these lines will remain very important. Line 1 is the iliopectineal line, is representation of the anterior column. Ilioischial line is line 2. It represents the upper extent, the quadrilateral plate, lower extent, the medial border of the ischium. The acetabular roof, 3, and then you've got the anterior wall and posterior wall. This representation is very important, and it's very important to diagnosis. طيب, الهيب center of rotation. Hip center of rotation is very important. زي ما احنا قلنا إن هو it's one of the goals of revision surgery. It could be altered in revision, and it's very difficult to pinpoint it, but you need to template and operatively plan. So the lines اللي موجودة في الdiagram ده, you've got the lower ischial line, and you've got the line across the iliac wings, and you've got the vertical line going through the medial border of the teardrop. And many researchers have looked into this, and mostly the center of rotation will be around 77 millimeters above the ischial line and 33 millimeters medial to the teardrop line. The height of the socket is usually about 20% of the height of the pelvis. So that gives you an idea where you want to put your new acetabular component. Some investigators insist that even 1 millimeter of medial or lateral displacement of the hip center of rotation can result in early loosening. Other researchers say that high hip center is absolutely acceptable. But a high hip center comes with other things. You need to look at your abductors, and you need to think about how you're going to put your femoral component, because quite often you have to compensate for the high hip center by putting your femoral component high. Cross-sectional imaging is very important. CT scan or SPECT CT to prove that you've got a loose acetabular component is very important. 3D reconstruction gives you an idea of what you're looking for, how far your component is displaced. You can also use a CT scan if you are going to request a custom-made acetabular component. Then it's mandatory. You send the CT scan and the company fabricates the component for you, but these are really expensive. I don't think they're available across the Middle East. Magnetic MR is very important. It can give you additional benefits. MR will let you know about potential muscle damage. لو انت عندك الابدكتورز طلع في الMR ان انت عندك الابدكتورز فيهم fatty infiltration. These abductors are not functioning. You can't rely on them. And you need to think about alternatives in terms of stability of this hip. الMR كمان ممكن يدي لك معلومات تانية. الMR ممكن يقول لك إذا كان في soft tissue collection. لو أنت عملت MR للعيان وطلع في soft tissue collection, then you should aspirate this. لو عملت MR والMR قال لك في one of the sequences is showing possible osteomyelitis, you need to consider that rather carefully. The quality of acetabular bone is, some researchers think that that's important. It's rather difficult to really assess the healing potential through the MR. I think a bleeding subchondral bed is the most reliable idea. It gives you the best idea whether this is going to heal or not. نيجي بقى for business classifications. في classifications كتير. The most famous the American Academy of Orthopedic Surgeons classification by D'Antonio et al. I've not put a picture for that, but it basically says type 1 segmental, type 2 cavitary, type 3 combined, type 4 pelvic discontinuity, type 5 arthrodesis. One little problem with that is we normally, the classification systems are in terms of ascending order of difficulty. Actual speaking, segmental defects can be more challenging than cavitary defects. فهنتكلم دلوقتي على Paprosky classification, و this is what most people use. Paprosky is type 1, type 2, type 3. Type 1 is, we're going to speak to them in detail, but type 1 basically is minimal bone loss. You've got an acetabular component that looks pretty much like a hip after being reamed and drill holes, just like minor defects. And type 2 is, now we've got more defects. 2A is superior bone loss, which is mostly capillary with an intact rim. 2B is superior lateral displacement, and 2C is superior medial displacement, and then there's type 3. Type 3 has got more significant superior and medial displacement, with 3B mostly representing pelvic discontinuity. طيب نبتدي نتكلم على البابروسكي classification تاني. Again في in detail type 1 كل type من دول ليه specific criteria. With type 1 the teardrop is intact. The hip center of rotation, no migration. The ischium is intact. And bone loss is very mild. 2A, again, teardrop is intact. Mild migration less than 2 centimeters with intact ischium and moderate bone loss. 2B is got an intact teardrop with less than 2 centimeters superior lateral migration. The ischium is intact and the moderate bone loss. 2C has got some lysis of the teardrop. Now we're starting going medially with less than 2 centimeters of superior medial migration, some ischial bone loss, but the total is moderate bone loss. Type 3 is severe form of migration with the 3A moderate teardrop lysis and then severe superior lateral displacement with the ischium still mainly intact. The bone loss type with 3A has got a more of a vertical bone loss. So the bone loss is described as 10-2. So it's in the center in line with the superior migration. 3B is more of a superior medial migration and is more broad. So the bone loss is like 9 to 5 o'clock with severe lysis of the teardrop and the ischium. So operative planning, now we're sitting down to discuss what we're going to do for this patient. Is it going to be a single stage with intraoperative sampling or 2-stage? Always be prepared to go to 2-stage if you open and you find tissues that look infected. Just be prepared for that eventuality, even though if you've done your homework and done everything, you go in, you find there's appearance of infection, go 2-stage. What are the anesthetic requirements for this patient and monitoring? Does he need ITU? Does he not need ITU? And you need to have his blood requirements and everything else. What is the surgical approach? Are you going to use a posterior approach? Or is the patient done through an anterolateral approach or a lateral approach? This needs also to be agreed. How are you going to manage the acetabular defects? What graft materials are you going to be used? What are your access to bone bank? Can you request fresh frozen femoral heads? Can you request allografts? Can you request strut grafts? Are you going to use metal, trabecular metal augments? Are you going to accept a high hip center? These are all questions that need to be asked. What is the effect of the bone deficiency on the acetabular orientation? Will you manage to put the acetabulum in the orientation you want? What is the degree of constraint? Are you going to use a standard hip articulation? Is it going to be a larger head? Are you going to use a 36 head? Are you going to use a dual mobility? Are you going to for a constrained hip? Femoral side pathology. What are the repercussions of a high hip center? Are you doing a cement in cement revision? Are you using a distal fixation? Are you going to put your prosthesis a little bit proud to compensate for the vertical height? These are all questions that need to be answered. Now let's speak about some of the specific types. So Paprosky type 1, as I said, resembles a normal acetabulum, following reaming and drill holes. You've got a supportive rim. You've got a cancellous bone stock, which is more than 50%. You've got an intact teardrop. You've got an intact quadrilateral plate. The ilioischial line is not breached. You've got a normal hip center rotation. Everything applies. You can put any components you want. You can put a cemented component. You can put some particulate or bone graft, cancellous bone graft. You can put a all polyethylene cup. The only question really is whether if you're using an uncemented cup, are you going to put screws or not? I'd rather put screws in the context of revision. I can't really say I can put a blind cup. So this is a case presentation. This is a 79-year-old female with the index procedure done 20 years ago with this elite prosthesis. She's got a loose acetabular component, which is proved by CT. Negative workup of infection. And it's confirmed by the fact that she had 20 years pain-free function in the hip and started becoming painful in the last year, which is always a very reassuring scenario. Somebody who's had the hip for 20 years was happy with it and then started becoming painful. So this is acetabular loosening. So this is the type 1. Basically, you've got the ilioischial line is not breached. You've got the teardrop is intact. And you even got your femoral components got a stable cement mantle. So the decision is straightforward. There's a revision of the acetabular component by using a ingrowth prosthesis, using screws for augmentation, and a cement-in-cement revision of the femoral component. With good function, it's a straightforward case. It doesn't become any easier than this. Type Paprosky 2A. You've got progressive superior bone loss. This doesn't necessarily need to involve the rim. This is actually one of the pictures in the index paper, and you can see there is a osteolysis in the superior aspect of the head. So this needs to be filled, and basically it's particulate bone graft, allograft, impaction grafting. This is definitely a viable option. You can use bulk allografts. You can use that as well. But mainly you need some biological solution. You need to fill in this gap. So again, type 2A, you've got an intact rim, no superior migration, no teardrop lysis. The medial wall is intact. You can use fresh frozen femoral head impaction allograft mixed with vancomycin, which is, has healing potential, has bone morphogenic proteins, and you can reverse ream it, impact it, reverse reaming, and then put an acetabular component. You can use an uncemented component. The prerequisite is you need at least 50 to 60% host bone contact. If you ream it and you find there's plenty of bone contact, you can use an uncemented shell, but you need to fill this gap one way or another. What I'm saying here is an intraoperative assessment is very important. You can't rely on your preoperative assessment, say my preoperative assessment says that this is so-and-so. Once you remove your prosthesis, then you do your secondary assessment because you might find that things have changed considerably and you need a backup plan. You need to have a mesh at hand in case you want to do just an impaction grafting. If there is the lateral wall is now not containing the defect, you need to put something to contain the defect. Type 2B is more significant superior lateral migration. Again, the ilioischial line is not breached. The teardrop is intact. The quadrilateral plate is intact. And proximal migration is less than 2 centimeters. Options for reconstruction, you can use an oblong, bilobed, or large components. These are all valid options, subject to the anteroposterior diameter of the acetabulum allowing that. You can use a mesh augmentation, so you can apply a mesh on the lateral wall and then impaction graft and use a cemented socket. That is also a viable option. Or you can use trabecular metal augment and impaction grafting and cementation. Some people choose to put an uncemented component. Again, the thing is, once you've done your augmentation, you've put some biological means of lowering your hip center and you're doing an impaction graft or whatever, you need to make sure that if you're using an uncemented component, you need to make sure that whatever bed you have has ingrowth potential, bleeding subchondral bone, and the contact is in the region of 50% or slightly more to give your component a chance. If you're implanting your component, which is resting against a trabecular metal augment, then you struggle to think how's that's going to heal, what's going to heal. Metal is not going to heal onto metal. Now, this is another case that we've treated rather recently. Now, this is a resurfacing hip and was done 12 years ago. There has been a negative workup for infection. Again, it's really difficult to put this in terms of classification because migration here could be more than 2 centimeters. The anterior and posterior walls are relatively intact, but still considerable degree of migration, but still there is no teardrop lysis. There is no destruction of the ilioischial line. So it's difficult to put it as a 3, but it's definitely somewhere between a 2 and a 3. The management here was through a trabecular metal augment, impaction grafting, and the cemented component. The hip center is not brought to normal, and you can see the compensation by keeping the femoral component a bit proud, but on balance, for what the patient had, he was very happy, and he rehabbed quite well. Paprosky 2C becomes a little bit challenging because you've got medial and superior migration. So the medial wall has been breached. The quadrilateral plate has been affected. There is some lysis around the teardrop. The original Paprosky paper even mentions using a wafer bone graft for the medial wall. Actually, we need something a bit more robust because that medial wall, if it's not sealed, then your graft is going to go inside, and the patient, once he weight bears, everything will be displaced medially. You can use trabecular metal augments for this type and 3A as long as you do some impaction bone grafting on top of them. Now, this is another case. A 72-year-old male with a loose acetabular component. Index procedure was done more than 15 years ago. Again, a negative workup for infection. The medial wall is unreliable, so we've requested a CT scan. And when you look at the CT scan on the coronal cut, you can see that that medial wall is very thin, and almost there is some perforation or breaks. And look at the axial cut. Look at the amount of thinning in the medial wall, and anteriorly, the anterior column has become very thin as well. So we need some type of reconstruction here. We can't just put, we need some bone grafting. So this is a method that we use quite often, really. And basically what we've done, we've used 2 fresh frozen femoral heads. We've got the, they've been morselized, and then this is a mesh. And what happens here is we impaction graft medial to the mesh. So we apply a layer of impaction grafting and impact it more superiorly and less tightly medially. Otherwise, we're going to breach the medial wall. Apply the mesh or screen, and then some more impaction grafting. Now we've got the metal screen in place. It's going to protect that graft from displacing medially, and then a cemented component. And the results of this technique are quite good, and they yield excellent results. For the femur side, it's been an intact cement mantle, and the patient had a cement-in-cement revision. This is a case who's been shared with me by Dr. Hussam Elixir, who's doing his MD thesis in these cases. And this is, again, another patient who had a type 2C loosening and migration, and has been managed quite nicely using a trabecular metal augment sealing the medial wall breach, and then impaction grafting and a cemented dual mobility cup with excellent reproduction of the hip center and limb lengths. It's quite a good case. When we go to the more severe cases, going to Paprosky 3A. Now, this is a case with significant superior bone loss and migration, more than 2 centimeters, moderate teardrop and ischial lysis. You have to reassess these cases. If you think that you've got a 3A, you have to reconsider during the operation whether this is a pelvic discontinuity. You need standard cup and augments, so you need all options. So there's a few options available: trabecular metal augments, impaction grafting with an uncemented or cemented socket. Trabecular metal has a porosity akin to bone, and it has excellent biological potential, and they heal and provide a stable platform to be able to reconstruct the hip underneath, and they reduce the need for massive bone grafts. And if you think that healing with a particular bone graft or a morselized graft takes a lot of time, then a bulk or structural allograft will take ages and ages to be substituted by normal bone, and that might never happen. So this gives you a very good option. Good to excellent results were obtained by this technique with about 80% success and biological fixation, which is very good results in a category of patients where reported complications after revision for massive acetabular defects, complication rate can be as high as 30%. Now, this is an interesting case, one of the cases done in our institution. And basically, we're talking about a 62-year-old female who presents with a loose right acetabular component. This is already a revision case. And apparently she had her hip done 20 years ago, and immediately after she had dislocation. So this is the result of her revision. Now, her hip center is basically where it's supposed to be. And you might wonder why I classified her as a 3A. But then you have to look at the amount of bone cement here. It's got a massive cement mantle that really, once this is removed, we're looking at a 3A. There is some breach medially of the ilioischial line, some teardrop lysis, some ischial lysis, but generally, this is the main problem up here. The workup for infection was negative for her, and there is some polywear on the right and even more severe on the left, but the left was not as symptomatic as the right. So this is what she had done. She had a trabecular metal augment superiorly, an impaction allograft with fresh frozen femoral heads, and the dual mobility cup. And this is her follow-up x-ray, and it has healed nicely. She had a cement-in-cement revision, but she had some restoration of height, and you can see that her non-union of her greater trochanter has slightly distracted more, but still she functioned well with good function. Now the dreaded Paprosky 3B. These are complex conditions to manage. And to be honest, we refer them to tertiary referral center. There's a few centers in the UK who can manage these cases. And for these, you need a biological and biomechanical solution. Bridging construct attached to the ischium and ilium combined with structural particular graft. And looking at this 3D reconstruction, it shows you the size of the problem. You've got massive lysis of the medial wall. You've got very little and almost no connection between the superior aspects of the anterior and posterior column and the inferior aspects. Now, this is a 72-year-old male who's had a hip replacement about, at the time of that radiograph being done, was about a year down the line, and he presents with progressive acetabular loosening and pain. Quite surely, this proved to be an infection through high inflammatory markers and an aspiration. It's a bit of a complex problem, but sure enough, that patient had a first stage with extraction of the components and a cement spacer. And he was improving in terms of inflammation and infection, having a long course of IV antibiotics for 6 weeks. But then A follow-up showed that, sure enough, that the temporary spacer found its way into the floor of the acetabulum, and now we've got a pelvic discontinuity. And basically, this is as difficult as it gets, because imagine you're treating an infected non-union, you've got an infected pelvic discontinuity. So this is really difficult to treat, and the patient has been referred onwards to a tertiary referral center, awaiting his final procedure, or potentially a number of debridements before he can be reconstructed. Pelvic discontinuity is a distinct and unique challenge during revision total hip arthroplasty. The superior ilium is separated from the inferior ischopubic segment through the acetabulum, and then the anterior and posterior columns are discontinuous. It represents like a transverse acetabular fracture. The operative management of acetabular bone loss is one of the most difficult challenges. Common treatment options include cage reconstruction with bulk allograft, that's an option. Triflange acetabular components, usually they are also, the triflange components, they have an acetabular hook, but bear in mind that an acetabular hook across a very thin inferior part of the acetabulum might not be the best option, might not be very solid. There is a technique called acetabular distraction. Basically, you apply an uncemented socket between the two segments, and it acts as a segmental strut through the recoil of the pelvis. But then you're keeping your hopes very up, waiting for that to heal at biological fixation to the superior and inferior aspects, which sometimes is a big ask. Now, just to give you an idea, these are the triflange cup, and this is one of the cases that was mentioned by one of the references in this presentation. And basically, you've got a pelvic discontinuity, and then they applied the triflange cup with a acetabular hook. But you look at these serial radiographs, and you can see the hook is cutting through. Now, previously, at the number B, you don't have a lot of protrusio, but then there is progressive protrusio as the hook cuts through. And bearing in mind that you're putting this hook across a very thin shell of bone. So the current concepts meeting in Las Vegas 2018 say that a hemispherical acetabular component with posterior column plating is a good option for acute pelvic discontinuity. You can have an acute discontinuity if you have a periprosthetic fracture. Somebody fell and had a transverse fracture. So you can remove in these situations the acetabular component, apply a posterior column plating from the ilium to the ischium, and then put a component on top of that. That is a valid means, but bear in mind that most of these are chronic conditions with an established non-union. So what you need is actually a component that has at least 3 screws and 3 screws above and below the discontinuity, and addressing the discontinuity as a non-union, where you refresh the fracture ends, apply biological means that would enhance the healing through a fresh frozen allograft or an autograft, and then a stable acetabular component on top of that. A cup cage construct can be used. This includes a highly porous acetabular component. A polyethylene liner can be cemented on top, and there's a number of plates and rings you can use. The carabal ring, the octopus ring, you've got many names, and there's many ways you can fix them, whether you apply a part of it which is inserted through the ischium or screws to the ischium. And I said the distraction method, which is a very controversial thing. Now, this is a custom-made triflange, which is based on a pre-operative CT scan. And then this is the component, and this is how it's inserted. And this gives just a lot of options. You've got screws into the ilium, you can get screws into the pubis and screws into the ischium. This is a very stable, but this is a very expensive component. And it can be associated with a dual mobility cup. And then you've got the mesh, which is built in, where you can put the graft behind it. And this is an excellent means of managing such conditions. To summarize, management of acetabular bone defects in the context of revision is a very demanding condition. This needs special expertise. You have to realize that there is a ceiling to what you can manage. A thorough preoperative evaluation is mandatory, excluding infection. You have to go to the length, you have to get bloods, you have to look at the history, get aspirate or even samples if you need to. Operative planning includes approach, extraction of components. This is very important. You have to have the means, you have to have the tools. Many options available for reconstruction. Prepare management plan and then alternative management plans. Always go in with a plan A and a plan B. Don't leave yourself to, in a situation where, how can I manage this? Aim to reproduce the hip center of rotation, avoid protrusio, avoid lateralization of the socket, because you build up the medial wall too much, you end up with a lateral socket. You're asking too much of your abductors, you're increasing the forces in your hip, and then you're setting yourself up for failure. Aim for stable components that allows you at least partial weight bearing. This is very important. These are elderly patients. You can't expect them to non-weight bear for a long time. Obtain intraoperative samples. Any patient, consider this infected until otherwise. You have to obtain samples, you have to continue antibiotics until you get your samples back and they're negative. Once they're negative, you can stop the antibiotics and then things are moving forward. These are my references. Thank you.
Thank you so much, Dr. Ayman. And ده زي ما عودتنا حضرتك very informative presentation and very illustrative. يعني illustrations كلها والكيسز بصراحة أكثر من رائعة دكتور أيمن بيه.
ربنا يخليك يا فندم. والكيسز ده الكيس بتاعتكم مراتي.
لا العفو يا فندم، العفو يا فندم، مع حضرتك الفضل لا ثم حضرتك يا فندم، ربنا يديك الصحة.
لا ربنا يخليك. هي very concise. أنا حبيت إن أنا أدي بس
هي رائعة بصراحة و summarized everything.
يعني
أنا معانا دلوقتي يا حسام تلميذ حضرتك طبعا هيبقى
ازاي ده حسام ده جراح عظيم.
ولو تسمح لي ابدا اول سؤال لحضرتك يا دكتور ايمن.
اتفضل يا فندم.
هو from your long experience how much do you allow في الهاي هيب سنتر يا فندم ان انا استعمله، بالذات ان انا في الكيس البوليو اللي سعادتك مشكورا عرضتها اللي فيها resurfacing. I think this is a very high hip center. So do you prefer to do acetabular reconstruction ونحط الهيب في its position بالرغم من ان هو بيكارز very high risk dislocation، ولا حضرتك proceed بهاي هيب سنتر وده بيبقى risk of dislocation اقل بس حضرتك loosening later on longevity of the prosthesis نفسه doubtful شويه. حضرتك ايه رأي حضرتك؟
هو دكتور محمد الحقيقه هي depends how much can you bring the hip center down. لو انت تقدر تجيب الهيب سنتر داون للاناتوميكال هيب سنتر ده يبقى شيء عظيم. الحاله دي كان فيها مايجريشن حوالي 3.5 او 4 سم. الترابيكولار ميتال اوجمنت اتحطت مكان الفولس استابلم formed by the loose component. There is some researchers who say that a 14 millimeters of impaction grafting is about what the body can heal. فهي الفكرة ان احنا النهاردة حطينا البيولوجيكال component trabecular metal where the defect is by default، وحطينا تحتها حوالي 14 millimeters of bone graft. يعني لو انت متخيل ان في حد يقدر لو انا احط مثلا 2 centimeters of impaction grafting, the body will not, because this impaction grafting needs to be accepted, needs to be replaced, substituted by normal bone. The biology of the patient will really struggle to if you look at patients who've had a massive amount of impaction grafting, the failure rate is high. And everyone can consider this in his own experience. لأن في ناس بتشتغل كله by impaction grafting and mesh. Their experience could be better than mine. لكن أنا بالنسبة لي أن أنا أعتقد أن هو to accept a bit of a high hip center, considering what we started off with. We started with something like 3.5 centimeters. We went down to about 1.5 centimeters of a high hip center in relation to the anatomical hip center, and we decided to stop there. Otherwise, we'd be putting too much graft, expecting too much healing from the patient.
Thank you, sir. دكتور حسام، هنبدأ الكويستشنز لبروفيسور أيمن.
تمام دكتور أيمن، يعني thank you for this interesting talk. يعني I have a question. If before the operation I found that there is abductor deficiency, should I do يعني trochanter osteotomy and transfer, or can I do fascial transfer? What do you prefer?
الابدكتور ديفيشنسي موضوع صعب، ان هو حتى اللي هو في تكنيك described by Whiteside اللي هو فاشيا، اللي هو تنسور فاشيالاتر ترانسفير to compensate for abductor deficiency is not a standard procedure، واللي بيعملوه مش كتير. انا شخصيا عمري ما عملته، ولو اني انا I've heard of it and it's something I'd be interested to consider. If you've got abductor insufficiency عن طريق non-union, then you don't need an osteotomy. It's already, you've got nothing يعني in connection. I think still the practice, if you've got no abductors, then a constrained hip would be the way forward, and accept that this patient will walk with a Trendelenburg gait. Trying to reconstruct the abductors is not a standard practice, and this is something might be looked at in the future, but at the moment it remains an answer to abductor insufficiency is either whether you have some function, then you can use a dual mobility or tripolar, or you have no function with high risk of dislocation, then you're looking at a constrained hip.
Okay, thank you. And also another question, after doing reconstruction using allograft, when should I start with bearing? After the graft be united, or can I start from the next from the second day?
We start second day partially with bearing.
Partially bearing, تمام. Okay. Okay. After using trabecular metal augment in the reconstruction, should I do reaming before putting the cup, or just putting the cup?
trabecular metal، لو انت هتستعمل trabecular metal وبعدين انت هتعمل impaction grafting قصدك؟
لا، هستخدم، يعني انا مستخدم trabecular metal augment وحاططها دلوقتي، يعني لازم استخدم ريمر مقاس الكاب اللي انا احطه على الtrabecular metal augment، ولا احط الكاب على طول؟
يعني لو انت هتحط كاب ايه، هتحط cemented ولا uncemented؟ cementless. My point of view is if you're using a cementless cup, then you need at least 50 to 60% host bone contact. تمام؟ انت مش هتقدر ان انت to expect biological fixation ما بين allograft وهوست بون، ومن الناحيه الثانيه الالوجرافت and the cup. This is rather يعني دي فكره طموحه زياده عن اللزوم. فانا I'd rather ان انت you ream before you put your augment، والا if you're reaming against your augment then there is a problem. You will get metal debris and that is not ideal. So if you ream before your augment, you just realize where you're putting your augment, and then you ream and then you see where you're putting your cup, and then you put your augment to support your cup, then that's fine. I think that's reasonable practice. Or you can ream, put your cup, put the screws through the cup, and then apply your augment and the screws on top to support it. That's an option. وممكن يكون في ناس بتعمل عكس، بس ده كل واحد حسب الاكسبيرينس بتاعته.
تمام شكرا. There is no more question.
Any questions to دكتور أيمن؟ احنا مش عايزين نتعب الدكتور أيمن أكتر من
كده.
لا
عينيا، لا تحت أمركم.
برضه سؤال لحضرتك دكتور أيمن بيه، كان الفيري انترستنج كيس اوف تروكانتريك نون يونيون مع الديول موبيليتي كاب. هو معروف ان الديول موبيليتي كاب بيزود الاستابيليتي، but do you think that the dual mobility cup is enough when we have abductor insufficiency and trochanteric non-union?
هو اصل في حاجات احنا شايفينها في الاشعه وفي حاجات مش شايفينها.
Yes.
احنا شايفين non-union لكن that could be a fibrous non-union.
Yes.
There could be still a connection.
Absolutely right. Yes.
Also لسه بقيت الصورة المريض ده pre-operatively Trendelenburg بتاعه كان ازاي؟
Yes.
نمرة 2 intraoperatively you will trial your hip. If you put a dual mobility and then your chuck test is negative and you've got a reasonable range of movement and it's not coming out, then that's all what you need. The main problem is once you go to a constrained hip وحضرتك عامل reconstruction وtrabecular metal وbone graft, then you're putting a lot of strain on the prothesis cement interface, and then it's a matter of time before this fails. So you, on one hand, you want more stability. On the other hand, you don't want a constrained hip. فاحنا الحقيقه ما بين زي ما هنا بيقولوا between a rock and a hard place. You want the best reconstruction and you want to give the patient as much as freedom without putting too much strain on your reconstruction. So it's really difficult.
وده يعلمنا برضه يا فندم ان مش كل حاجه radiological evaluation. I have to do clinical evaluation. يعني ممكن زي ما حضرتك بتقول يكون في fibrous union وستيبل functioning abductors، بس هي حضرتك radiologically نفس الشكل اللي احنا شفناه ده.
تمام
فندم. دكتور ايمن بيه، احنا في نهايه اليوم الجميل ده بنشكر حضرتك شكر جزيل، وانا
شكرا ليك يا دكتور محمد.
واصل قدامي من كافه الاخوه من كافه الدول بصراحه يعني.
لا تحت امركم، ويا رب يكون
احنا شاكرين افضل حضرتك
يعني
والمحاضره القيمه دي، ودايما بنسعد بتواجد حضرتك معانا يا دكتور ايمن بيه. والله
انا اللي بسعد يا دكتور محمد، تحت امرك.
ربنا يخليك يا فندم. ان شاء الله يعني نشوف حضراتكم جميعا على خير يوم الجمعه الجايه، برضو زي ما الدكتور ايمن يعني اخ عزيز وحبيب وفاضل. ان شاء الله معانا الجمعه الجايه بروفيسور وليد قشطه من جامعه ماكماستر في كندا، رئيس قسم العظام في جامعه ماكماستر في كندا، وهو برضو صديق عزيز للدكتور ايمن، كلهم اخواتنا الافاضل يعني. فدايما بنسعد بتواجد حضراتكم معانا ان شاء الله. ان شاء الله ميعادنا الجمعه الجايه ونراكم على خير باذن الله. شكرا جزيلا دكتور ايمن بيه.
شكرا دكتور محمد.
تصبح على الف خير.
شكرا دكتور ايمن.
شكرا دكتور حسام. شاكرين يا حبيبي.
شكرا دكتور محمد. شكرا دكتور ايمن.